Hello, everyone, and thank you so much for joining us today. I'd like to introduce our webinar speaker, Daniel Giers, and he is a licensed clinical professional counselor with a master's in clinical psychology from the Chicago School of Professional Psychology, and he has an MBA from Southern Illinois University. Currently, he has a private practice in counseling in Champaign County and is part owner and clinical director of True North PTSD Center. On his off time, he speaks publicly to professional psychology programs, news affiliates, and universities on stigma, treatment, and recovery in a variety of mental health and trauma-related topics. We're so happy to have you this morning. Daniel, thank you and welcome.
Well, thank you very much, Debbie, and I really am glad to be here because I think that there is a lot to be said about bipolar disorder. And one of the things I like to bring to the topic is the fact that not only do I, spend several days of my week treating bipolar disorder, or as some people, continue to refer to it as manic depressive, but I also am a sufferer of bipolar disorder. I've been dealing with this for a good long time in my life, and I know that some people who are in the professional field know that when you're a child, when you're young, they usually try not to diagnose what ends up being such, a pretty hefty a diagnosis. But it's been going on for a really long time, starting with a manic episode I had back when I was 16. Followed by a depressive episode, and then it's kind of gone back and forth, and I didn't really have a name for it until I kind of ended up meeting a really good psychiatrist who told me, you're going through some things right now, here's what it is. And it was interesting because being labeled was really difficult at first, but then I realized that there's a bit of a power to the label because on one hand, you start to realize that you're not alone. You have the ability to research what's going on in your mind and in your body, and you start to have an idea of, here's ways that I can actually start coping and solving the problem instead of just wondering, what is going on inside. So I like to think that what I bring is, a bit of both sides of the fence. On one hand, here I am taking care of people that are going through the same thing, but, having my own understanding. So again, thank you for having me, and I really hope you guys get a little something out of this, and we'll have some questions towards the end. So I'm going to go ahead and get started then. Okay, so I'll just skip past this really fast, but as Debbie introduced, I am a licensed clinical professional counselor here in Illinois, and I have a master's in clinical psychology, specifically with a PTSD specialization from the Chicago School. It's a really great program. It's very professional based, and they really teach you a lot about diversity, and they're very strong in the entire anti-stigma part of dealing with mental health, because it can be very easy for us sometimes in the opposite chair of the client to say, like, okay, well, I see this person as their diagnosis, and of course, we were trained very well to see somebody as a human being, as a name, as a mother, a father, a brother, a sister, etc., as opposed to a couple of numbers and some scary words behind them. I also have a master's in business administration, specifically in the healthcare management field, which has been pretty darn helpful in starting up a PTSD clinic, though I have to laugh when I say to myself, and I really truly mean this, I truly sometimes think that I learned more in my MBA about psychology than I did in clinical psychology because of the fact that it was so practical, and it's like, here's how people react to things, employees and customers. So it's a good combination of programs, I'd say. And again, we'll skip past this pretty quick too. Working as a clinical director has been very interesting for this upcoming PTSD center. It's been on hold right now for probably about another year, just because we've had some business things that we're working on right now. I do work as a psychotherapist here at Compass Counseling in Champaign, and then prior to this, I have done a lot of crisis work for several hospitals. And this is the type of work where when somebody comes in, if they're self-harming or feeling suicidal, or in an uncontrolled manic state, I would help them decide whether or not they could benefit from being psychiatrically admitted, if you will, and then of course, helping to facilitate that process. It's interesting work because it's a well-known thing in psychotherapy that the first time someone tells you that they're in a crisis, it's almost like a fire, kind of explodes in your head. You're like, oh my God, what do I do? But then when you do this and do it 1,000 times in a row, it kind of gets a little bit easier. I am a veteran of the United States Air Force. The reason I mentioned this is a big part of why I wanted to be part of the PTSD world was because of my work in the Air Force. I had a technical job, so I had nothing to do with medicine or psychology. But during my time, I did some shadow work with a psychiatrist in the PTSD clinic. And I really started to find out that there was so much more to the world than just the body. I was a former paramedic in Cook County in Chicago, and not necessarily for the Chicago Fire Department, but for a private ambulance that did some 911 work. And I had come to find out that there was a lot more interest in the mind than there was in the body. So that's just my little introduction. Now, to really kick off the presentation, what I usually like to do is ask the panel and ask the organizer and ask the viewers and listeners to allow me to break a couple of rules. Rule number one is just kind of a rule as far as speaking goes. Normally, when you make an introduction about yourself, that's the time to tell a little about your professional and personal achievements, who you are. However, what I'm going to ask you to let me do is actually introduce myself in a much different light, so I'm kind of do two introductions. And then the other rule I'm going to break, I'll kind of get to in just a moment. So let me introduce to you what the real me is. And here's where rule two gets broken. When we work in psychotherapy, psychology, social work, psychiatry, we don't ever refer to somebody by their diagnosis. And the reason is, and we'll get a lot more into the stigma a little bit later, but the reason comes down to you dehumanize and delegitimize the experience of a client when you refer to, I'm just going to pick a random name here. Let's say I had a woman named Kate who was suffering schizophrenia, some psychosis. You really dehumanize and delegitimize her when you say something like, oh, that's schizophrenic, or oh, that patient with schizophrenia. There's really a lot of power to words, because if you think about my client or Kate versus that schizophrenic or that person with schizophrenia, you really kind of start to feel the difference rather than see a difference. You're taking away who she is as an individual, and you're prioritizing her diagnosis, the science behind it, the medication, all these sorts of things, instead of realizing that you have a human being across from you. However, in this introduction, I'm going to ask you to allow me to break that rule, and I'm going to tell you a little bit about who the real me is. And that's why you see these little fancy codes here, like F31.32. These are just diagnoses from the DSM-5. That's our little Bible of how we code the various disorders. So yes, I am a sufferer of bipolar disorder, and I have been for at least a good 20 years or so, since about when I was 16, when I had my first manic episode. The MRE part just means most recent episode, depressed, and then the F41.1 talks about generalized anxiety disorder. The reason I do this introduction like this is because A, it gives you the idea of who I actually am underneath when you don't see what I'm going through when I'm in my higher functioning type of days. But I also like to do this to use myself as an example of what it's like to kind of look at me as a disorder instead of a person, instead of Dan as a therapist, a horse rider, a husband, and so forth. I like to allow myself, because I know that I can handle this a little bit, to let people stigmatize me a little bit, just almost the practice of seeing what it's like to say, well, instead of Dan, our presenter, here's this guy with bipolar disorder, or here's this bipolar guy. So it just kind of gives you a little bit of flavor, and I know how ugly that can be when you say those things, but I think it's important for us to really honestly look at what we're facing. Pardon me, sometimes my voice seizes up a little bit, so. The last major depressive episode I had was back in August of last year. It was a pretty terrible time for me. It was a moment where I was eating something about 200 or 300 calories per day, and being an individual who's 6'4" and a little bit overweight, I might say, and that's pretty dangerous for someone like me. The last manic episode I had was back in 2010, and the reason I put those question marks behind remission is because you just don't know, and we're going to get into that as well as time goes by. So let me tell you a little bit about my day. On Monday, Tuesday, Wednesday, and Thursday, I actually work at a substance abuse center here in central Illinois, doing specifically and exclusively substance abuse work. So during that time, I'm working with people who are perhaps on probation or parole and who have issues with drugs and alcohol. And we're working on the counseling side of it, trying to help people work through what's going on in their life so that they can get away from what is very often a quite dangerous habit. And then usually on Monday, Wednesday, and Thursday, I'll have private clients after, with the exception of Wednesday, I have online clients where I actually do either text-based or video-based. It's all HIPAA compliant, but video-based clients, and it's a really, really cool addition to my caseload, because this would give otherwise unable to reach clients the access that they need to get some good professional help. On Friday, I work exclusively with my psychotherapy and private clients, and a good portion of them are PTSD clients. That goes from 9 a.m. to 6. Occasionally might have somebody on Saturday, but you'll see that I've got, unfortunately, there's not enough room on the page for how many exclamation points I want after the word self-care on Saturday and Sunday, because you'll see me pop up this set of words on my slides several times here, because it is just so very important, and not just for professionals and not just for people who suffer mental illness. But just, for anybody, because we need to take care of ourselves. So on Saturday, you can almost always find me on the tennis court. It's one of my favorite activities. It's really great because, you really get a lot of exercise. You have to think, you have to be a little bit analytic when, you're hitting back and forth, knowing where the ball's coming for you. But if nothing else, it's something that's completely away from the norm. It is something that I love to do, and it gets me out, it gets me exercise, and which exercise is so very important when it comes to either depression or bipolar disorder. And then on Sunday, my favorite day of the week when it comes to horse riding. I've been a horse rider since I was about 13 years old. And I always like to make the little joke as well that not only have I been riding horses since 13, but I've been falling off horses since 13. I've been a hunter jumper, which does include the tight pants and the fancy coats and jumping over fences, and it's just something that's been freeing for me. And I really find that the self-care from horses is absolutely unbelievable, because here we are, with this half-ton animal who is, in my opinion and estimation, the best conversationalist ever, even though they can only make a few varying sounds that we don't 100% understand. So we'll talk a little bit more again about self-care. But now, just like with my introduction, I want to tell you about my real day, the day that you would not normally see if you were my client or my coworker, or somebody who didn't know what was going on inside. So here's my other day. Typically, my day starts at 7 a.m. when I wake up. Between 7 and 7:15, I try to practice a little bit of mindfulness exercise, and I'm going to detail that here in a moment. At 7:15, I have my morning medication regimen, and this is what helps to keep me at a balanced and stable level. It's very important. I have had times, and I'm not going to go into details about what I use, what I take, but it's very important for me to continue on this, because a missed day of medication to someone who has suffers something like bipolar disorder can be very, very dangerous, both physically and mentally. Again, at 12 p.m. when I have my lunch, I usually do a little bit more of a mindfulness work. And then at 8 p.m. I have my evening medication regimen and try to get to sleep around the same time every night, because somebody who goes through bipolar needs a ton of consistency in their life. They need structure. They need personal accountability, if you will, when personal accountability can be exceptionally difficult. So let me talk to you a little bit about the mindfulness exercises. The mindfulness exercises are just simple ways for me to test and see where I am. And when I say where I am, I don't mean where I am physically or geographically or anything of the sort, but more about where's my mind, uh, where's my spirit, where's my soul, where am I at, where's my body. And it's important for me to check in on a frequent basis because it gives me hopefully it gives me very good clues about things seem to be on the downswing right now. I notice that my energy is much lower. I notice that I'm not eating as I usually do. I'm overeating, I'm undereating, my sleep is getting a lot worse. Or on the flip side, I seem to have a little bit too much energy today. This might be getting to hopefully not too close, but it might be getting close to a dangerous position. And so that mindfulness is really important for me to keep track of where I am. And it's again one of those things I recommend to anybody. You don't have to have mental illness or physical, chronic pain or disability, but just to check in where you are each day. So what does all this mean? It is really important for me when it comes to treating other clients, especially those who have bipolar disorder or depression, to keep active and aware of my state of mind. And it's very important for me to keep active and aware of my state of mind for just a variety of reasons. But number one, it comes down to if I'm not able to help myself at that exact moment, then I'm not exactly able to help somebody else. And you'll see like my fifth bullet point there is a CPR analogy, and I'll talk about that very, very briefly. But it's important for me to keep aware of how I affect clients, and this to me is probably one of the most important parts. Imagine for a moment if you were a sufferer of bipolar disorder and I was having a hypomanic or a manic state, and all of a sudden you come in. It's actually very easy for me to set somebody else off, because I, at that moment, represent a dangerous state of mind sometimes for somebody else who might suffer the exact same thing. So it's really important for me to keep aware and know that maybe I'm not in the best moment of stability for someone else. On the flip side of that, it's good to keep aware of how clients affect me. One of the best analogies I can make for this is someone who has suffered some sort of trauma, whether it be long-lasting or single event. It's very important for someone who's a trauma therapist to remember and always keep track of how are their stories affecting me, how is the client affecting me, to make sure that I'm giving myself good, healthy care, but also to make sure that I'm not again reverting back to how I affect the client. So I asked a moment ago to imagine if you were a sufferer of bipolar disorder and I was in a manic state and set you off. Well, imagine the exact opposite if somebody comes in a manic or depressed state, and how that could set me off. And so all of this kind of comes together into knowing when you need to take a break. And quite frankly, taking a break is important to everybody in this world. If you work, if you care for somebody else, you have got to know when to take a break, when to have those selfish moments and say, okay, right now I am at a point in my life where I'm suffering some burnout, or I'm suffering what we in the industry call compassion fatigue. And compassion fatigue is very dangerous because it's different from burnout, because while burnout affects the mind and the body to where you're just tired, you don't want to do the work anymore. Compassion fatigue comes down to these moments where I am emotionally burnt out, and you can find yourself not being concerned for what's happening in the chair across from you. So it's very important, and I want to take a break. And so doing so requires you to keep self-care in the forefront. Alcoholics Anonymous is a group that I'm sure many are aware of, a 12-step group for people who suffer addiction to alcohol. And they talk about self-care, and they talk about making it a selfish program, meaning that you have to take care of your addiction first. And that is so very true when it comes to psychiatric or psychotherapeutic or social work care. Because if you're not enough for yourself and you can't take care of yourself enough, then how am I going to be able to take care of this a very deserving person who's in the chair across from me? So the CPR analogy is really simple, but it's very profound. So CPR, for those who don't know, stands for cardiopulmonary resuscitation, and that's if someone were to stop breathing and their heart stops beating, that's where you breathe and do the compressions for them, so to try to keep them sustained until a paramedic arrives or until they can get to the doctor. And there are actually, believe it or not, if you're a CPR card holder, there are many reasons why you can stop CPR. One, of course, is if the person begins to breathe again, for obvious reasons. But one that people forget is that it is legal and ethical for you. If you are suddenly so exhausted that you could no longer perform CPR, you are expected to stop. And there's really two reasons for that, and it's, again, profound when you think about it from psychotherapeutic standpoint. Problem one is that imagine if you're doing CPR and you become so exhausted that you now become a second patient, and the ambulance shows up and now they have two people to work with. But two, imagine if you're so exhausted you have to think of how well are you doing the breathing or the chest compression. So if you switch that idea back over to therapy, if I'm not at my best, or at least close to my best, how effective am I going to actually be for my clients who, again, I repeat, are very deserving of my best? And so what is mania and depression? I'm really not going to spend more than a moment on this. As you can see, I'm linking back to the International Bipolar Foundation under their learning area of the website, and they'll give you a really good idea of what symptoms of mania and depression are and what they really mean. But I'll just give you an idea of inside what it feels like. The depression is typically a little bit better understood because there's a lot more dialogue about it. I think this country feels a little bit safer, and perhaps even the world feels a little bit safer talking about depression, even though it's still very stigmatized. It's a little bit more discussed because things like depression and anxiety and PTSD are becoming a little bit more, I guess what I would say is recognized and allowable, or allowed, if you will. So, depression, talking about, fatigue and lack of energy, lack of interest in hobbies, lack of interest in, self-care and just kind of living your life. Whereas mania, it's a little bit harder to understand because it's not talked about nearly as much, and that's why I think this foundation is wonderful, because it deserves a lot of recognition, because I like to be brutally honest and say that it is dangerous. Mania is marked by a rather severe increase in energy and what we call goal-oriented behaviors. And goal-oriented behaviors might be things such as excess shopping or excess spending, excess eating, and all the way up to things such as excess intimate or sexual behavior, which, as you can see, putting two and two together, how that can become dangerous. But let me give you a little insider view of what mania feels like. Mania to me is always, the best way I can put it is, the brain chemistry takes over and tells you that you're alert-oriented and you're just absolutely high on life. And while for most people part of the stigma is, one of the stigma comments that's pretty frequent is, wow, I would love to feel manic. I would get so much done. Well, let me just tell you that that's absolutely untrue, because there's two severe problems when it comes to mania. Number one, you don't actually get anything done. You only feel like you are. And the reason I say you don't actually get anything done is because when you're manic, you actually are so over-involved in whatever process it is, you're not even paying attention to detail or the perfectionism or the quality of what you're doing. It's all about quantity and getting it happen over and over and over. And the other problem with mania is that you can't turn it off. Short of having some pretty strong instantaneous medications, it's going to keep going. And because your body starts to realize something's wrong when it's getting torn down because of its excess energy and its excess behavior, but your mind says, no, unfortunately, it is not time for you to stop. You will stop when I tell you to. So if you hear someone say the words that, oh, I would love to feel like that, I would love to have a discussion with them, because I'd be happy to tell them the actual honest truth there. So psychotherapy for bipolar disorder. I like to just kind of give a very, very, very important but brief preface here that nothing that I am about to say should be considered personal counseling or advice. And in fact, I'm not going to give counseling or advice regarding this particular slide. What I'm really going to talk about is just the extreme generals of what's involved for proper psychotherapy. Cognitive behavioral therapy is really good because CBT is essentially based off the idea of recognizing the patterns in your life and kind of how things how you can recognize inappropriate or unhealthy behaviors or thoughts that are coming up, and kind of getting that back to action, so you can learn to recognize when things are becoming manic or when you're starting to become depressed, and kind of try to get a bit of a foothold and say, no, okay, I see something's happening, it's time for me to act. Whereas psychodynamic therapy is typically used in combination of or after CBT. Once awareness kind of increases, in psychodynamic therapy goes a little bit deeper and kind of talks about what are the internal processes of my life, what are the dynamic masks and that I show everybody each day. What are the roles that I play, and where did all these thoughts come from? Because yes, it is a chemical process, but at the same point in time, those who suffer bipolar often have sometimes a rather rough life, and so they have a lot of things to work through from their past, and which will have a direct effect on their present and their future. Interpersonal therapy is really about getting down deep into how you relate to yourself and how you relate to others. And it's, again, a good combination with the two above, cognitive behavioral therapy and psychodynamic, and so forth. Now, family support therapy is really interesting because a lot of people don't think that, that there's really any effect outside of the person who's going through bipolar disorder, which is absolutely untrue. Again, if you go back to thinking about things like addiction, there's some corollaries there in that addiction affects the family, but so does bipolar. If you consider that, if you love someone who suffers bipolar disorder, I've never really met someone that said, oh, my husband or my wife suffers bipolar disorder, or my son, and it's just absolutely a wonderful thing. And understand that I don't say this to say that in a sarcastic tone, to say like, oh my gosh, somebody has bipolar disorder in my family, I can't stand them, because it's not the typical truth. The truth is that it's easy to love someone who's going through mania or depression, but it's hard to love what they're going through. And so family support therapy is really good because it kind of gives the family time to say, like, to learn and to get educated as to what's going on with their loved one. And then, of course, there's caretaker therapy, and this is something that is just woefully unused, and people don't really consider that if you caretake for someone who goes through, especially a rather severe form of bipolar disorder, that you need a little bit of help too sometimes. So it's very important. It goes right back to that idea of self-care. So let's talk about the pros, cons, and dangers of my service to the community and to my clients. And there are definitely pros, and they're usually very easy to see. There is an understanding of the symptoms. When someone tells me that I had a manic episode for 2 weeks, I can understand to an extent that, okay, well, I've been there myself, so I know what it's like to have that uncontrolled energy and not be able to stop myself. Understanding of the episodes, which includes the depressed episode and the much less understood mixed episode, which is characterized by both depressed thought, fatigue, but also high energy. And it's unfortunately a very, very dangerous time in someone's life because, and I'm not going to go too detailed because I'm not looking to trigger anybody or to get rather morbid here, but if you consider being depressed but having a lot of energy, you can see how that could be rather dangerous. The ease of transfer into the therapy process is really great because imagine if you were suffering imagine if you were suffering bipolar disorder and then all of a sudden you were working with someone who suffered bipolar disorder. It might be rather easy for the client to say, oh my gosh, it's so nice for someone to know what's, what I'm going through to an extent. And then of course there's just the safety and understanding, the ability to instantly recognize when things are becoming unsafe, and understanding where it is. Now, here's where the problem lies. A lot of people hear these pros and think, oh my God, you must be a godsend, and you must be the greatest thing that ever happened in these people's lives. Now, admittedly, my ego would like to say, well, yes, thank you very much. I am quite the greatest thing that ever happened in life, but obviously, I like to be very aware of what the cons are. And here's where the cons begin. It all comes down to overgeneralization. Overgeneralization is if you were sitting across from me and you were telling me about a manic episode that you had 2 months ago, where you racked up $30,000 of card debt, and your credit score has taken a nosedive, and there's a lot of things going on. Instantly, if I'm not careful, I can start thinking, I know exactly how you feel, but the problem is I don't. And I know I hark back to the addiction analogy, but imagine if for a moment, I don't know how many people are in this room, but let's say there's 10 people in the room right now, and all of us had the exact same addiction for the exact same amount of time, and we took the exact same amount of pills, the same time of the day, et cetera, et cetera. You gotta get my point. My question would be, did we all suffer the same addiction? And the answer is an emphatic no, because none of us have the same chemistry, the same biology, the same, essential physics of our body and the psychology. We're all different. We feel pain at different amounts. So no, I do not know how that person feels, and that can lead to mind reading if I let it go too far. Oh, good, I went a little bit too quick here. And the mind reading comes down to like, I know what's going to happen next, and I know how this person is feeling, and that can lead to improper treatments. And then, of course, there can be a bias in both directions. A bias in that I absolutely love this client, so I am never going to accept the fact that something dangerous or bad can happen. Or it can be that, oh God, here comes this person who's depressed again. I don't want to deal with this, and I'm not going to give them my best. Now, it unfortunately does not end there. The pros and cons are not the only thing when you have to actually consider what are the dangers of my service. Severe overgeneralization and that bias can lead to me missing something, missing a sign that someone might be in a bit more of a crisis than I actually thought. Setting off a client with my mania, setting myself off with somebody who's going through mania or depression, although sometimes it can be a little bit easier to be set off by a manic episode. But having that overgeneralization and missing something, if I can be bold and blunt about it, can lead to a loss of life. There's really no other way to put it. And generally, it's not always that severe. But missing something, and a client doesn't show up, and I'm just thinking, okay, well, it's probably all fine and dandy because I'm fine and dandy right now. I'm not going through mania, so there's no way he could be going through that. I'm not going through a mixed episode, so there's no way he could go through a mixed episode. So it's it's really, really interesting. So yes, there are dangers, and we really have to go back to what I said about taking care of myself and knowing where I am so that I can be aware of my overgeneralization and my mind reading. So how do I care for myself and the client? And we've got a couple more slides to get through, and then there's going to be time for questions. So believe me, I'm going to leave plenty of room for that. So how do I take care of myself? Self-awareness, which I feel like I've hit that up plenty, so we'll go ahead and move on. Vigilance is probably one of the most important things. And vigilance, if you think about it, is that constant, consistent, in the moment awareness of where I am. But the vigilance, instead of just being self-awareness, adds the consistency to the message and saying to myself, not only am I going to be self-aware, but I'm constantly going to be on top of my self-awareness. And that comes down to saying, like, okay, checking into myself instead of maybe once a week, 5 times a day. Okay, Dan, where am I right now? Okay, it looks like I'm doing okay. Or, okay, Dan, where am I right now? Well, I'm feeling a little lower than I would like. Maybe it's time for me to look into or have an extra session with the therapist that I see. Coworker awareness and supervisory awareness. Now, this is where things get a little bit interesting. And I'm going to pass over those for a moment because we're going to hit that in a second. And as I said, the medication regimen, which we already talked about, so I won't bore you guys with that again. But just to say that it is exceptionally important that if you have somebody that is suffering bipolar disorder, that there is no missed medications. Now, don't take this the wrong way for me to say, like, oh my goodness, my husband or loved one missed a pill. Everything's going to become a disaster. No, it really just means that things can go very wrong if somebody misses their medication. Obviously, if you have an issue with that, you should not be talking to me. You should be talking to a doctor, their psychiatrist, because they're the medical professionals. And then, of course, self-care again. I told you that this would be repeated, and here it is again. Really, what I ought to do is just have a little bit of, kind of like an undertone, maybe a watermark behind every slide that says self-care, just as a way to kind of put it in your mind over and over. So I skipped again. Let me go back a couple here. Unfortunately, I've got one of these touchpads that if you even think about going to the next slide, it says, okay, we're ready. So self-care has to be genuine, selfish, and loyal, and that essentially means that genuine means it needs to be something that's actually relaxing, something away from the norm, not work that you do at home, or not something that seems relaxing, but it's really not. It's got to be genuine. It needs to be selfish. It needs to be something for you. I've often remarked that I'm a pain in the ass when it comes to my clients because I will ask them every single time, what did you do for yourself last week? And then make it loyal. Make it something for you. Make it consistent. It's got to be right for you. Okay. Um, so let's talk about the big question that a lot of people ask me over and over when I go to undergraduate programs. Can I be a therapist if I suffer mental illness? Yes, you absolutely 100% can be a therapist, but there are a lot of considerations that you must take into consideration. I kind of repeated myself, but there's a lot of considerations. Number one, are you safe? You have to know if you are safe to do what you're about to do. I can't say enough that therapy is the greatest career field I think that's ever existed. I think it's wonderful that people sit down and actually allow me to take a very private, painful, and personal journey with them. You can't even fathom, unless you've done the job yourself or been part of that, to say like, wow, somebody is actually sitting in a chair and essentially paying me money to say, I'm going to open up all my wounds and I want you to walk with me. That's just an incredible thing. But you need to know, are you going to be safe during the thought process or after the actual client sessions? And are you safe with the client? Are you going to be set off? Are you going to set them off? Are you stable? And then comes the big question of disclosure. What do you want to disclose and who do you want to disclose it to? We always say in the psychotherapeutic realm that disclosure to a client has to be for a very specific reason, and that means it's going to actually help the client themselves. So you can't disclose and turn it into your own therapy session. It actually has to be something helpful. But more importantly, should you disclose it to your boss or to your coworkers, and what's the benefits and what's the dangers? And believe it or not, there are benefits, especially when you suffer something that can cause instability. I have disclosed to all of my coworkers, and I've done that for the singular reason that I want my clients to be safe. I am very selfless when it comes to that. My clients, when they sit in my chair, are going to get my best and they're going to be safe with me. So if I don't recognize the fact that I'm feeling manic or feeling depressed, maybe somebody else will, and that's really important to me. Are there dangers to disclosure? There absolutely is. Some people may use it against you. Both clients, bosses, supervisors, coworkers, society, there's a lot of stigma attached to it. And of course, because of how a lot of acts such as the Americans with Disability Acts works, and it's not exactly legal or ethical or professional for someone to relieve you of your duties unless you become a legitimate danger just because you have a disability, and mental health is a disability. So what does the world need to know about bipolar disorder? And this is my last slide before we get to questions. The world needs to know a lot about bipolar disorder, and that's why I think that the International Bipolar Foundation is just such a wonderful service. Just before we started the slides in the presentation, Debbie and I were talking about how very needed this is because it's so misunderstood. Sufferers of bipolar disorder are not weak. These are people that go through things that many can't understand, sometimes in their worst nightmares. And the same can be said for things like PTSD or schizophrenia or depression or anxiety, is that, it's hard to understand unless you've actually been there. We are not weak. We are actually very, very, very strong, especially when you consider someone who goes through bipolar disorder and actually decides to get help by it. You're actually opening yourself up to stigma and saying, I have had enough of this, and essentially, damn society, I'm going to take care of myself. Sufferers of bipolar disorder are not broken. We have a chemical imbalance and we have chemical differences from many other people, but that does not mean that we're a broken item that should be kind of just cast aside in society. If you read back all the way even up to the 50s and the 60s, people who were suffering bipolar would essentially be locked up, almost, permanently when it comes to, some of the asylums that used to exist, because it was society's way of saying, I don't actually want to deal with it. Now, I understand some people can come by it honestly because it's hard to have these discussions, but we need to have these discussions. It's very important. Sufferers of bipolar disorder can be infinitely successful. Having a mental illness has nothing to do with your level of success. It's just going to have to be personalized and individualized. And most importantly, and I really mean this, if you or someone you know suffers bipolar disorder, you or that person deserves amazing amounts of empathy and compassion, because you or that person are going through something that is completely difficult. It's extremely dangerous. It's just a rough way to live life, and you deserve to be treated. And I'm going to repeat that again. You deserve to be treated just like anybody with a physical disorder. Simple and plain as that. So essentially, that's what I have for right now. I'd like to thank you for listening. You can read a little bit more about me and my journey at the website I have at informedmind.net. And then also, I have included a slide for the IDPF themselves. Please, if you have the ability, make a donation. And if you don't have the ability, just learn a little bit more, because their resources are absolutely wonderful. So at this moment, I'm sure Debbie will come back in, and I think it's time for questions.
Yes, thank you, Daniel. Thank you for sharing your story, your insights. We much appreciate it. It looks like the first question is coming in, which I'll read to you. What is your feeling about bipolar being treated without medication?
That's a really solid question. So thank you for whoever may have asked that. It's really hard for me to separate my bias from my personal life, both professionally, but I'll tell you how I feel about it, honestly. If you can find a way to treat bipolar disorder without medication, then please, by all means, do it. If you can, if somebody can stay stable and have a good, healthy life, without even a single drop or a pill, that's absolutely wonderful. I truly do honestly believe, and I know I get crucified by this by my own colleagues, but we are over-medicated in this world, or at least in this country. We over-medicate quite a bit. The one caution I always give when it comes to bipolar disorder is that because it is a chemical process, sometimes I have run into many, many cases, and it doesn't mean invariably. There are certainly, cases that can go without. But sometimes with bipolar disorder, medication kind of has to be the right of way before any real work can be done. But that is not to say that it is impossible. And I have seen folks that have gone through it and found such amazing mindfulness and almost a Zen nature about it, to where they can be so self-aware, and people around them are so aware that they don't need necessarily to have a chemical assistance. So, do I believe that that's the majority? Not necessarily, but I do believe that it's out there, and it's an important question. So thank you.
Thank you for that answer, Daniel. The next question. You spoke about the importance of taking a break when you need one. How do you determine when you need one, and how does that affect your patients, since consistency is so important for sufferers? And knowing this, how do you avoid any guilt that may come with canceling sessions, etc.?
I really want to give a hardcore shout out to the fact that that person who asked that question added that last little blurb at the end. So let me take care of the professional side of it first. First of all, how do I know? Again, the self-awareness, but that's where my colleague awareness and my supervisor awareness, but also the awareness of my wife is, very important to know. But if it's just in my own mind, I have to ask myself the question, am I safe? But more importantly, is my client safe right now? Okay, so if I remember properly, part two of the question is, how do you deal with it professionally when consistency is the key? And then the guilt kind of ties into that. Professionally, I have, or if you're a therapist, you have an ethical duty to make sure that if you are not safe, that you are not trying to do something that is going to harm a client in any way, shape, or form. It's essentially the exact same thing as me pretending to know how to do some, technique or pretending that I'm a psychiatrist when I'm just a therapist. We have an ethical duty to make sure that the people in our chair get the most appropriate care possible. So it's kind of a two-part answer in that. If you have to take a break for a week or something, and it happens once a year or twice a year, it's understandable. And I have found so far that my clients have been very understanding. In fact, I've had a few clients say, like, oh my gosh, is there anything I can do for you? And which, I mean, it just speaks real deeply to me, that I've got that sort of relationship. However, sometimes, episodes can last a month or more. At that point in time, it's very important to communicate in the safest way possible, to your clients that there's some things going on, and being brutally honest and upfront, not necessarily about what you're going through, but that I am not going to be able to serve you properly at the moment. Is there some way I can, get you either temporary help, with someone else before I come back? Is there something I can do, trying to make concessions? So it's definitely difficult. I've been relatively lucky that the longest I've had to take off was 2 weeks a few years ago. But let me tell you about the guilt. The guilt is very legitimate and genuine and real, because here I am thinking to myself, my God, these people are absolutely, relying on me to be consistent. And here I am calling them 2 days in advance saying, listen, I'm going to have to cancel. I'm so sorry. And the guilt will never disappear, but a big part of that comes down to the fact that I know that deep down I'm doing the right thing for that person. If I take myself out of the equation, I'm doing the right thing for that person. So that helps the guilt be assuaged a little bit.
Excellent. Thank you for that answer. The next question, have you found peer-led support groups to be helpful to bipolar clients you've worked with? And if so, in what ways?
So let me just make sure I understand. You say support groups such as like a bipolar support group that's not necessarily professional in nature?
Yes, correct.
Absolutely. Oh no, non-traditional support groups and traditional support groups are absolutely an invaluable experience, both for me as the therapist and for the clients themselves, because, pardon me, because one of the things that I always say I'm famous for saying. I'm not exactly famous, but one of the things I'd like to be famous for saying is that when you come and see me for an hour a week to work through something like bipolar disorder, you have to consider that there's another 187 hours in the rest of the week where I am not going to be part of your direct life, meaning that I can do as much as I can in the therapy session, but then there's this massive amount of time in between weeks, or in between sessions that you have to consider. So the support group, there's a lot of bonuses to it. Number one, it's extra help. Number two, it's less professional, and you get to just be yourself, and you get to be yourself with other people that have a lot of things in common with who you are and what you're going through and suffering. So the benefits are enormous, and plus, it's nice to just be able to talk, and it sounds silly to say, but to joke about some things and to actually, get a little bit of levity and humor in your life and say, like, yes, what I'm going through is awful, but for once in a while, can I at least just have a little laugh or a sigh of relief about it, instead of having to constantly kind of delve deep into, this is what's going on. So for the few clients that have taken up the offer and gone to something like a bipolar support group, they have found it infinitely helpful, because here's just a bunch more people who can actually just sit and be bipolar. I know that sounds, kind of stigmatizing to say, but they can just sit and be who they are and say, you know what, I've got a problem, and so do you. We're going through the same issue. Let's just have, like some coffee or tea, or let's, have a little bit of a snack or dinner and just talk about what life is like. And quite often, a lot of those support groups, from what I understand, will start as in, okay, so let's check in, but now it ends up devolving into, this TV episode here, so it's just, like-minded individuals and people going through the same thing, being able to just relax. So, very good question.
Great, thank you. The next question, excuse me. There are some follow-ups, excuse me. How do you deal
Oh,
with
absolutely.
how do you deal with coworkers that have stigma because you're a person with lived experience, even if you work in the mental health field?
Mhm. I'm just going to be quite honest with you. The fact that just because I'm in the mental health field does not mean that the stigma doesn't exist. So that is an extraordinarily relevant question. People who, the biggest stigma that I will deal with is not so much what I suffer, it's that people think that I have no business whatsoever doing the work that I do. Um, I wish I could give you a real magical and rainbow laced answer in saying that it's all fine because you're going to face the stigma and you're going to be strong and it's just going to be better. But really, the answer comes down to at some point in time, you have to find a bit of information or a bit of confidence in yourself and say to yourself, I am just going to do the job that I know that I do well. And essentially, I'm not going to be concerned about what society thinks. And don't get me wrong, when I say that that's extremely hard to get to that point. You don't just wake up one day and say, like, ah, the hell with what everybody thinks. I am just going to be strong and I'm just going to say, like, boom, I don't care what you think about me. But over time, you have to find your own support group outside of where you work and people who are going to be very genuine and loving to you, even if it's not someone who's in your family. And that's going to be your strength. And then you're going to find your own internal strength through their strength and to say the fact that, you know what, you're not in the sessions with me and you don't see, what I do. So you can take me or you can leave me. As long as I'm not acting illegally or unethically, then, I'm going to be who I am. But that's a really, really a good question as well.
Great, thank you. Next question is, are you on medications? And if so, do you get mania?
Yes, I am on medications, and again, I won't go into the details of what they are, but one of the medications I take is actually something called a mood stabilizer, without going into the names of them. The mood stabilizer is specifically built to keep the manic symptoms from going down. I'm very blessed that I have not had a manic episode in the last 6.5 years coming up on at this point in time. But to say that it's impossible would be incorrect and false. We have what we call breakthrough episodes, meaning that the medications are doing the best they can, but sometimes the chemistry just takes over. So, I don't mean to make light of the situation, but knock on wood, I have not had a manic episode in 6 years ever since I found the actual appropriate regimen for me. So it's been very, very helpful.
Great, thank you. Next question is, if you are publicly speaking and have a website disclosing that you have bipolar disorder, how do you handle clients who find out about you through those methods, even though you might not have felt the best interest for them to know about your diagnosis and your checklist?
It's only happened once or twice. It's only happened once or twice at this point in time, and I laugh a little bit because, I sit here and I tell people that, you've got to know what to disclose and when. I'm not aiming in my life to be looked at as some powerful figure that's going to change the world because I'm just a single voice. And frankly, the ability to change the world is, millions of voices rising up at once. So I really hope that what I'm about to say doesn't come off as a bit of an ego trip, but I'll be blunt about it. It's more important for me in the individual. Of course, the clients are the most important people in the world to me when we're in that session, but it's more important for me that if I can be used as an effective tool to show that that you can succeed and you can be who you want to be despite this nasty disorder, then to me, even with the clients, a couple of clients that have seen it, both responses have been, oh my God, I didn't know that you're going through this same thing. And it did open up a dialogue. And yes, there were some negatives that could potentially come through it, but the ultimate goal was that, so all this time, one of the clients asked me, so all this time that you've been working with me for 7 months, you've been going through your own thing, and yet here you are, being successful and you're doing all these things, and I find that amazing. So again, it's not an ego trip, but it's a reality to say that somebody who goes through something like addiction or bipolar disorder or mental illness or physical disability and succeeds, will, I think, more than not, offer up a view and say that, hey, I'm a success despite what I'm going through, and you know what, you can be too. So the part that sounds very egotistical is I'm going to say is that I kind of don't care, because in the moment, my therapist or my client is the most important person in the world. But it is equally, if not more important, for me to remove the stigma, because if you think about it, if somehow I was magically to wave a wand and remove the stigma, imagine how much better my client's life would be, who also suffers bipolar, that when they walk out of my office, they don't have to worry about the next person saying, ew, you suffer bipolar disorder, you must be a murderer, or, you must have, done really terrible things in your life. So it's a balance, and it has to come up. But to me, thus far, it's been very, very positive, and it's important for me to help do even the littlest bit I can to remove the nastiness out there about bipolar disorder. But again, that's a really powerful question to think about. So thank you.
Thank you, Daniel. The next question. I am a university student on a Christian campus, and I live with bipolar disorder. When I am in a manic episode, my sex drive goes through the roof. I cannot speak openly about this without getting shame. How do you recommend I deal with this? I do go to counseling and take medicine, but I need friends who understand, and I feel very alone.
Okay. Well, first of all, I'd like to speak directly to you for a moment and say that, I'm sorry that you're going through what you're going through. Um, it's very difficult, of course, and in the face of it, of course, there's nothing wrong with Christianity. I know, several people who are Christian, very accepting of a lot of things, but obviously there's some cultural considerations to have there, because, as I said, sex drive can go through the roof uncontrollably when it comes to mania. So building that strong support group is exceptionally important, and just being honest with yourself is going to be the first step that you're going to take to finding your own inner strength. Having that ability to say, you know what, I'm going through something that I cannot control. And you have to remember that over and over again, that this is not something that you ask for. This is not something that you can just snap off and say, okay, I'm done. I'm done being manic now. It's okay. Um, and having enough of a support group, whether it be family, friends, including things like, your psychiatrist if you see one, or your therapist, to help you build that inner strength. And you say you talk to a counselor or a therapist, and maybe you have brought this up, or bringing up to them and just saying like, hey, I am feeling, very weak right now. I am feeling, that the culture of the school that I'm in right now is really looking down on me, and this is hurting me. What can I do? Um, but ultimately, there's going to come a point, I believe, in everybody who's willing to take the chance, that you'll end up finding your own inner strength, and being able to say that, yes, there are realities of stigma and that they can be harmful in your professional or personal lives, but knowing that you are a strong individual. And I don't even know you, I don't know your name, I don't know where you live, and that's okay, but you are a strong individual. And if I can say this to anybody who may have the same follow-up question, that if you suffer bipolar disorder, I want to tell you, and I don't mean it as a cliche, and I don't mean to say it just because I'm with you in this, you are an exceptionally strong person to be able to get up every day and know that these things happen, and that they could switch on a dime, and that all of a sudden you can turn in and have a manic or depressed episode. To be able to get up and be who you are every single day, I think is just one of the most fascinating and powerful journeys, and this is not to minimize anybody else who doesn't suffer, because we're all human beings, but just try as best you can every single day to remember that you are deserving of empathy and compassion, and you are deserving of treatment, and you are, despite the episodes that you go through, a human being first, and someone that deserves to be loved. And hopefully that'll, over time, instill in your mind and become a habit to say that I'm a strong person and I deserve it. So that's probably about the best I could say, unfortunately, at the moment.
Wonderful. Thank you for that very thoughtful answer. The next question is, do you feel that psychiatrists have the responsibility to highlight their patients' side effects of antipsychotic medicines, such as weight gain? Um, see, we'll just leave it at that. How do you feel about?
Okay. So when we talk about highlighting, I guess I would ask for one piece of clarification. Do you mean like if I go in to be seen for bipolar disorder that they should talk about side effects with me?
I believe that's what they're getting at. Yes, absolutely.
And I think that's what I assume. And I just wanted to make sure that I answered the question as it was stated. Yes, I think it is very, very important. Um, I know that, when you listen to some of the side effects that can potentially happen, because antipsychotic drugs are strong drugs, there's no question about it. I believe it is terrible to be dishonest, and dishonesty can happen. I think some of us have heard the term lying by omission, meaning I'm not telling you a falsity, but I'm not telling you the whole truth. Informed consent is a procedure whereby we let you know everything that you can stand to gain from what you're doing and everything you can stand to lose from what you're doing. So, if I were to come in, and again, I'm not going to pick a random pill, but if I tell you that I'm a psychiatrist and you come in to see me and I'm going to put you on an antipsychotic, I think it's unprofessional and unethical for me to say, here's what you can benefit from. Your mood might start to stabilize, the manic episodes will go down, the mixed episodes will go down, and then end the conversation there. Um, because even if it's, just like even a standard, a much less, or a pill with a lot less side effects, such as something you might take for high cholesterol, it's important for people to have an informed choice. One of the first questions that you had asked me through the viewers was, um, how do you feel about somebody who might try to treat bipolar without medication? That is your choice, and you need to have an informed choice. And that's the most important word of that is informed. You are consenting to be treated by a doctor who's going to give you a chemical product. You need to know what's going on in your life. The only caution I think I would ever give to somebody is to try not to over obsess about what the potentials are, but just to be aware of, hey, this is what could potentially happen. That way you're aware of if all of a sudden a month down the road you've had an extreme weight gain, or some of the pills can actually cause extreme weight loss because there's no hunger, that you could say, okay, this is the cons are outweighing the pros here. So yes, it is important to me, I think, and I'm not a psychiatrist, I'm not a medical doctor, but I think it's important to know what you're up against.
Great, thank you. The next question, as a clinician, I wonder how you feel about using the word suffers from rather than has bipolar.
Yeah, it's something I've asked myself actually quite a few times. And I have to admit, I like to be an honest individual. I think I've gone through enough, and I think it's just become part of my lexicon of saying the word suffers from, because to me, I think it felt a little bit, softer than saying this bipolar patient or this bipolar client. But, frankly, I am not above reproach here, and I think that that's an important thing for me to start saying that maybe I need to start using that word instead, because perhaps what I'm going through is maybe not defining someone by their disorder, but in a way I might be um, inadvertently adding to the stigma by saying the word suffers. So I want to give a large amount of thanks, and I think that's going to help change my worldview a little bit. So I appreciate that, and I think I'm going to start using that from now on.
Great, thank you for that answer. The next and last question will be, how do you help someone who has the nature to easily give up? Do you have any suggestions?
Mhm. Um, for someone who has bipolar, yes, it is easy to give up, especially when you're in the beginnings of recovery and treatment and coping. There's a lot of motivational factors that I can spit out left and right, like asking questions such as, what is it that you want out of life? What do you think you can handle, and uh, see and do and act upon? What are you willing to do and see and do and act upon, to get things done? But um, the the truth comes down to the fact that if somebody is not ready for help, I don't ever want to say somebody doesn't want help, because that just carries such a negative connotation. Just in the way of saying maybe has versus suffers, I mean, that kind of carries a negative connotation, meaning that someone doesn't want the help to get some coping or recovery. Maybe it's that that person just isn't in the right space to get there. So somebody who's so readily easily to give up, I think that probably the best thing you can do is, if it's like a friend or a family member or a therapeutic situation, is just to try to drop the discussion of something like bipolar or the disease or the disorder itself, and just continue on connecting with the person, connecting with whoever this is that you may be referring to, or if it is you, finding some connection. And let's not even talk about mania and depression. Let's just talk about, how's your day going today? We ignore such simplicities every single day that we just want to be like, oh, are you feeling okay? Are you feeling depressed? Are you feeling manic? How about, again, I'm just using a random name. Hey, Kate, how are you doing today? How are things going? What'd you do last night? Allowing somebody the time and ability to not think about everything that's going on negatively, and just saying something simple like, hey, did you see that episode of so-and-so, on TV? Or, did you catch that funny Facebook article that somebody posted? Making a real human connection. And if it's you personally, trying to make a human connection to somebody else, but more importantly, making a human connection to yourself, and remembering that you deserve these things. And don't make your life about bipolar disorder or depression or anxiety or whatever it might be. Make your life about you. Make your life about you first, and then you'll find times when you're actually ready to try to get the help, if you reach that point. And then at that point in time, you'll be, much more capable of going through days and weeks and not giving up. So again, make it about yourself. Make a connection with who you are. Make a connection with nature if you have to. Just be yourself for once, and allow and remember that you're important in this world too.
Great, thank you. That will wrap up our webinar today. Again, many thanks to you, Daniel, for sharing your personal insights and your professional insights. And just a reminder to all that this webinar is being recorded and will be archived on our website to share or to review further. And we hope to see you at our next webinar. Everybody have a wonderful day.
Thank you very much.